Good morning, everyone. Welcome to the session Vaginal Atrophy and Lichen Sclerosus, Clinical Best Practice for New Therapies. My name is Eduardo Serrano. I'm the Chief Scientific Officer with StratPharma. StratPharma is a Swiss manufacturer of medical devices. And we are introducing today StrataMGT as an alternative solution to these problems. So we're going to be reviewing from current practice to what we believe is the new solution to some of these problems. So we have three speakers today. Some of them are joining with us online, and here on site it's me and Professor Ganazzani. Professor Ganazzani is going to be our first speaker. I think most of you know him very well, but I would like to introduce him anyway. So he is obviously an expert in gynecological endocrinology for over 4 decades and academic leadership and more than 60 years experience. He is a professor or has been professor in many universities in Cagliari, Modena, and Pisa until 2012. He is the past president of the International Society of Gynecology and Endocrinology and the European Society of Gynecology, and the past president of International Menopause Society as well. He's author in more than 700 publications, 40 books in the field, and yes, honorary doctorates in European universities. So it's a big pleasure to have you today here, Dr. Ganazzani.
Gracias.
The room is yours. Thank you very much.
Thank you so much, Dr. Serrano. I thank all of you for being here. And it's a pleasure today to speak on a topic which is touching directly my daily practice and what I can try to do to help women. I will speak of non-hormonal and non-steroidal gel in the management of vaginal conditions. As you know, the vaginal atrophy and the genitourinary syndrome of the menopause are two characteristics that we are following more and more in these years. But we have not to forget that fantastic organ can suffer also from infection possible, and then also vulvovaginitis of the different origin, and mostly one terrible chapter, which is vulvodynia, which is sometimes have also some psychosomatic implications, which are sometimes even more difficult to be treated than any infection by any kind of bacterium and virus. But what is one of the most difficult aspects is the Lichenoid Dermatoses, the Lichen Sclerosus in the vagina is something that we were facing, I remember, since always, but where the solution until now was not really obtained. And the quality of life for women is also depending from their genital status. Certainly, vaginal dryness, burning sensation, itching, and tenderness can touch the daily aspects of the women's life. And when they come to us for consultation and to suggest a treatment, you can be sure that at least until now, 50% of them, they will call you again after 1 week telling you that, doctor, I have that problem, still remain, it's burning, I don't know what to do. And mostly, another very humiliating aspect is the painful the dyspareunia, which is suffered by the woman, but not only by the woman, also by the couple, by the full couple, but also the husband, also, or the male partner, or the female partner are touched by that fact. And the painful and dysuria, painful urination, and painful bowel movement also are, even though the last one is less frequent, but also difficult for us to face. And as you know, in menopause, we have a huge impact of the lack of estrogen on the tissues, but also of the lack of androgen. I remind you that I'm a strongly supporter of the ISGE. And this brings to the lack of sexual intercourse, decrease of ovarian function. You know, all these aspects can touch this organ and can bring to the, not only to the dyspareunia, but by the fact that the woman, even in some situation where she's even more suffering. And then after a breast cancer, the treatment with tamoxifen, the treatment with inhibitors of the enzyme responsible of transformation of androgen to estrogen, they still make a more difficult situation for the woman. And when we have seen the entity of the vaginal atrophy, you can see from this graph how vaginal atrophy is referred as a symptom of the menopause. But if you can see also in the right part of the graph that 55% of women suffer chronically, and this is something which is strongly, it's not only for the suffering the patient, but it's strongly, it's strongly disappointing. Oh, I'm sorry, this happened also to the president of the Congress. Okay, it's strongly disappointing and we don't know what to do. From that one, you understand why we need to try to have solutions. And the solutions are also linked to try to correct the biology of what is happened. We have vaginal atrophy, and which is linked to the lack of estrogen production. We have a thinned vaginal lining, a loss of elasticity, which are the major causes of the suffering tissue. You can see, you know very well the picture, what is the normal aspect of the vagina. I remind you also that you have not only the lack of estrogenic stimulation, but we have the reduction of lamina propria. The lamina propria reduction is due to the lack of androgen, the reduction of DHA sulfate occurring during all the life, and also the reduction of testosterone and androstenedione. The symptoms are very known, the genital symptoms, the sexual symptoms, and urinary symptoms. If you believe how many times a woman she can urinate during the day, you understand how much frequently she have that sensation of and that feeling of unhappiness and of difficult life, and she loses the quality of life. And also the dyspareunia, she's touching also the partner, she's touching the daily life, the loss of libido, the dysorgasmia is something which is touching you in one of the most secret part of your personality and your life. And this is also touching for the doctor. Then the primary goal for us is the treatment of vaginal atrophy is to try to achieve and to relieve the symptoms. If we can, we have to relieve the symptom. And until now, unfortunately, this we were not able. We are not sure that we have the proper treatment to eliminate the symptoms in all our patients. This is not true. We have for the vaginal atrophy a huge series of treatment possibility, lubricant, moisturizers. We have estrogen products as cream, rings, tablets, and so on. Systemic estrogen hormone therapy, the addition local androgens too. And also we have also some physical therapies such as the laser. We have the SERM, the ospemifene, some nutraceuticals, and other also alternative and complementary therapies. But at the end of the day, this is not the solution for everybody. We still have patients where it is very difficult to go on. The treatment option and the indication are to achieve to correct the vaginal dryness, the dyspareunia, and the decline of vaginal estrogen, which is not obtained with all this kind of treatment. I remind you the symptomatic relief only, and it's fundamental, but we don't have active treatment for vulvovaginal atrophy. And also that this is a symptom that once it starts, it remains. That means it's a biological condition that you have to face, not for 1 week. It's not an infection that you can treat the agent or any kind of treatment can correct, and the treatment it can be done in 1 week or maximum in 1 month. This is a treatment who touch the woman for all the life. Then we need a treatment for vulvovaginal atrophy. We have the lower dose estrogen compared to systemic therapy. We have a cream, tablet, and vaginal ring. We can reverse a series of effects, but not in all we achieve the treatment. Certainly, we have to take care of the safety. We have some safety consideration. I remind you that non-hormonal therapy is recommended as first line in women with current or prior estrogen-dependent breast cancer. Vaginal estrogen long-term use in breast cancer survivor remain cautious, the long-term use, because you have to think if you have that condition, if you are a breast cancer survivor in your 40s or in your 50s, but you are thinking, hopefully to live until 90, then the treatment have to be conceived, not only at that moment, but for long-time treatment. And hormone therapy acceptance remain low globally, unfortunately, in the world, driven by safety concern, negative media perception, and social influence. And barriers to long-term treatment adherence include fear of adverse event and preference for lifestyle modification, and the lack, and we have also the impact of patient education. And certainly we have the real daily perception that ongoing need for effective non-hormonal alternative. They are still important and present. We have now for non-hormonal treatment the ospemifene. I remind you we have the phytoestrogen, we have the functional CO2 and ERG laser, but these are not treatment for everybody. And you know, for example, for the energy-based therapy, still we need to more consistent data to be sure of their efficacy, and their efficacy mostly in long-term time. I don't want to go on vulvovaginitis and what are the causes of vulvovaginitis and infective diseases. This certainly we have to treat the infective aspect, but still remain the symptom. You know well the vulvodynia, how difficult is the treatment, how difficult is also to correct the psychological impact that vulvodynia have. And you had here before Alessandra Graziotin, which is a master in this kind of treatment. And we have a huge series also of other clinical application areas, for example, where we can need. I remind you the post-procedure in post-vaginal rejuvenization, and the post-procedure in vaginal grazing and episiotomy, the incontinence-related dermatitis. You know, incontinence-related dermatitis is not something who happen only in 1 on 1,000 patients. It's something who happen in some cases after in elderly population in a very frequent condition. And we as gynecologists, we have to try to achieve the solution of the treatment. But I remind you also hemorrhoids and anal fissures, allergic and irritant dermatitis. Okay, the circumcision, this is quite more rare, but the balanitis is absolutely more frequent also in men. Then, you know, the couple, we need also treatment, not only for the woman, but also sometimes for the couple. And I remind you symptoms such as Sjögren and the radiation dermatitis and other burns who need to be faced. And for that one, we will show you now the data on something which is not yet in the market. Then this is the reason why you don't know. But you have to conceive. This was present in another market, in another area. It will appear now, it is in the States. It will appear also in Europe. But it's something fantastic. For that one, we have decided as International Society of Gynecological and Endocrinology to host a StrataPharma symposium here with us to give us some information for something which is unfortunately not yet here, but it will be very soon. And for that one, I think this is StrataMGT as an innovative gel indicator for the management of vulvovaginal conditions in general. But I would like you to remind also all the dermatologic aspects that I have show you before affecting the human life at that time. Then we will speak about the problem, which is the vulvovaginal atrophy and genitourinary syndrome of the menopause and the vulvar condition, which are highly prevalent. We will speak about the possible solution and the potential availability of a treatment which is suitable for long-term use, because these are situations who chronically touch the patient. It's not only an acute. The treatment will support mucosal integrity and clinical signs, and which is applicable across age group and also post-surgical care, and is an hormone-free alternative who provide symptom relief and who is strongly efficient and effective. I think we will have that StrataMGT. The key points is the effect for mucosal healing, the symptomatic relief, the hydration and gas permeability. It restores the barrier function, is non-reactive, it's non-absorbable, it's absolutely easy to use. And unfortunately, I don't know, because I have never used it. I had only some samples, but they disappeared very rapidly. And then we had the chance, we called Strat Pharma to invite them. You have to come to us, because we are just the right public to hear this one. Then I thank you very much, and then I leave to the other presentation, who really will explain, done by people who really have used the product. Thank you very much.
Thank you, Professor Ganazzani. So joining online, we have now Dr. Robin Fay. She's a certified practitioner by the Menopause Society, certified by the American Association as well of Sexual Educators. She's a fellow of International Study of Women's Sexual Health, expert in counseling and providing medical care to women, partners, also transgender people, and specializing in sexual health and cancer survivors, cancer patients, dermatology, and pain. Dr. Fay is joining with us online, so I am asking the room if the connection is ready. I hope it is. Dr. Fay, are you there?
Hi, my name is Dr. Robin Fay, and I'm coming to you from Philadelphia. I am a GYN at Jefferson University, and I'm here to talk to you about clinical best practice for lichen sclerosus, managing disease, symptoms, and patient quality of life. As we know, lichen sclerosus is a chronic inflammatory dermatosis, most commonly affecting the anogenital region. It's characterized by white atrophic plaques associated with itching, pain, scarring, and architectural changes. It most commonly is seen in postmenopausal women, though it can occur at any age and in any sex. When localized to the vulva, it is often termed vulvar lichen sclerosus, and that is where we are going to concentrate today. And we're going to talk specifically about people who were born with a vulva. The prevalence is estimated at 1 in 300 to 1 in 1,000, though likely it is underdiagnosed, and I've seen that specifically in my own practice. The sex distribution is predominantly affecting persons identified as female, and the ratio is female to male of 6 to 10 to 1. It has a bimodal distribution. It's in the premenarchal girl and the postmenopausal woman. These women could experience symptoms from mild to severe, and unfortunately what I have seen is the diagnosis is delayed by many years. It is a chronic condition, and I always emphasize to everyone, once the diagnosis is made, it requires long-term management. It can significantly impact their quality of life. It can cause sexual dysfunction, and they experience painful intercourse, and they therefore can avoid penetrative sex. It can lead to the breakup of their relationships due to the loss of intimacy. These women are affected for a lifetime, and they can develop squamous cell carcinoma, and that can be estimated to be at 2 to 5%, and up to 65% of vulvar carcinomas arise in the background of vulvar lichen sclerosus. So it is important to emphasize that treatment needs to be continued forever. The exact cause remains unknown. The current understanding suggests a multifactorial process. Autoimmune predisposition is questioned because autoimmune thyroid is seen in a lot of these women. These women we see autoimmune thyroid disease in affected patients with a specific HLA subtype. There's a genetic susceptibility. There are seen to be familial clustering, and this has been reported. There are hormonal influences, and there's also a question of environmental or mechanical triggers. Most probable cause of lichen sclerosus, there is autoimmune disorders that run in either families or in the same patient, with thyroid disease, alopecia, pernicious anemia, and lichen planus. There is seen a proliferation of monoclonal T lymphocytes, and there is also a high level of circulating autoimmune antibodies. Etiology, there's observed patterns of higher prevalence seen in low estrogen states, as we stated earlier, of the premenarchal and the postmenopausal woman. There might also be a possible androgen influence. However, there has been no definitive hormonal deficiency identified, and hormones may influence the tissue vulnerability rather than causing the actual disease. What we have seen with the pathophysiology is there is immune activation with a T cell infiltration. There's an activation of T cells which release cytokines, and the fibroblasts become activated. Collagen therefore becomes altered, leading to the fibrosis that is seen. What are the clinical features? Severe pruritus and chronic pruritus. These patients feel like they have chronic yeast infections. They're misdiagnosed as having a yeast infection. They come in and they say they have been treated for a yeast infection for 5 years before they are truly diagnosed with lichen sclerosus. They have genital bleeding, they have burning and dysuria, constipation and painful defecation, dyspareunia, anorgasmia. They have dryness. These postmenopausal women claim that they can't find a lubricant that is satisfactory for them, or they can be totally asymptomatic. What are the clinical features? Cigarette paper appearance, crinkling, it looks waxy, they have multiple fissures, they have hypopigmentation, they have a butterfly or a keyhole appearance. They can also have scarring and architectural changes, the fusion of the clitoral hood, the clitoral phimosis and scarring, burring of the clitoris, resorption of labial minora, introital narrowing, and it can cause recurrent tearing. You might not even be able to find their urethral opening. The fourchette has adhesions, and there can also be a classic figure of 8 shape to the lesion, which includes the perianal area. Here are typical findings of the hypopigmentation, the fissuring, the shiny or smooth skin texture or the waxy appearance. You see the mild ecchymosis or the petechiae, that fragile skin. With severe lichen sclerosus, you see even more scarring, the ecchymosis again, the architectural distortion. Again, you have trouble finding that urethra. The clitoral hood is fused. Therefore, she's going to have dyspareunia, she's going to have anorgasmia, there's the buried clitoris, and there's the introital stenosis. And hard to identify her anatomy. What do we use to treat? Our first line, ultra-potent topical corticosteroids, 0.05 clobetasol, if that is, and it's an ointment. The goals to suppress her inflammation, prevent progressive scarring and anatomical alteration, reduce her squamous cell carcinoma risk of that 2 to 5%, attain symptom relief, improve her quality of life. So toilet paper doesn't bother her, underwear doesn't bother her. She can be more comfortable. We tell her to rub it on her vulva twice daily for a month initially, then change to bi-weekly after that. Chronic treatment needs to be treatment for life. We can also use mild, medium to high potency steroids. These can be used for maintenance. We can use topical calcineurin inhibitors, emollients and barrier repair therapies. We can use Vaseline for her if she needs something on a regular basis for moisture. Intralesional corticosteroids for those thickened and refractory plaques. Systemic immunosuppressants such as methotrexate have been suggested for refractory. Now, these are the additional treatment options that are exhibiting experimental and limited benefits. We have the JAK inhibitors, the hormonal creams, the lasers, the inflammatory pathway inhibitors, which are showing limited studies, and evidence currently exists for some of them. Phototherapy and retinoids, all of them show limited, and they're experimental. Limitations of these existing treatments, adverse effects from LS treatment are uncommon, so therefore it's important for her to know that. The potential complications of steroid overuse are telangiectasia, steroid dermatitis, atrophy, and stria. They can be resolved by reducing the potency from the ultra-potent to the lower steroids. More prominent limitations exist because insurance companies, especially in the US, are high costs from the insurance companies, and also variable access are associated with these ultra-potent corticosteroids. So we need to go down to more of the lower potent steroids. There's also steroid phobia, which have been fueled by misinformation from pharmacists and also from the media, from online media, leading to lower adherence. People don't want to use steroids because they fear that it's going to do something to their bones, it's going to thin their tissue, and they're just concerned just because they fear using steroids. So we have a new medication out there, StrataMGT. It is a silicone-based topical formulation designed to influence the epidermal-dermal signal cascade by regulating the fibroblast production. It impacts collagen and production of glucosaminoglycan production. It reduces irritation by increasing hydration because these women feel dry. It supports the moisture balance. It's hydrated to have decreased production of the pro-inflammatory cytokines, the IL-1, IL-8, TNF, and COX-2, cytokine reduction leading to reduced collagen synthesis and scarring. Given these properties, StrataMGT could be effective in treating inflammation and scarring. StrataMGT was studied by Dr. Andrew Goldstein. He's one of the big guys in ISGE and in ISSVD. He did a study with 5 patients 18 years and older with biopsy-proven active VLS. Participants had 4-millimeter biopsies done at week 0 and week 10. StrataMGT was applied daily with no other steroid use. So it's not a steroid. There was no adjunct steroid therapy. The results of the StrataMGT study showed a decrease in LS symptoms measured by the Vulvar Quality of Life Index in 3 out of 5 participants. When they did the biopsies, histopathology demonstrated decreased inflammatory infiltrate between week 0 and week 12. It showed that in 2 out of the 4 patients. Here are my conclusions for today. Lichen sclerosus is a chronic condition. Its etiology remains unknown. It's important to manage the disease and manage the symptoms, which can vary among patients. Its quality of life for patients is so important, and ultra-potent steroids in the form of ointment is presently the standard of care to prevent risk of squamous cell carcinoma. Options at present can cause financial issues, and sometimes preconceived biases are going to prevent patients from treating it adequately. StrataMGT offers a new and exciting option for treatment. Thank you so much. If there are any...
Thank you very much. We will have the questions at the end of the session. Sorry for cutting the video so abruptly. The next speaker is Dr. Hall. Dr. Hall is a very experienced user with StrataMGT. He has been leading the clinical studies for StrataMGT for many years now. He's done himself in Australia several pilot and then bigger studies, and is currently as well leading the ongoing studies for StrataMGT in Australia. He's also the director of St. Andrew's Pelvic Medicine Center. He's a gynecologist and reconstructive surgeon with over 35 years experience in the private and public sector in Australia. specializes in fertility, menopause, and hormone treatment therapies. He holds multiple fellowships with various medical colleges, teaching surgical skills and other specialties, supervising the training of new techniques across Australia. He's an active member of several international associations and mostly involved in the management of urinary incontinence. We're going to be showing the studies that he has done with StrataMGT already and the published evidence, but also the preliminary data and the update to the preliminary data of the studies that are currently running in comparison with estrogen therapy for the management of vaginal atrophy. So with no further ado, Dr. Hall, it's a pleasure to have you in the room. I hope the connection works. Yes.
Welcome to you all, and I'm speaking from Brisbane, Australia. Unfortunately, I can't join you in person in Rome. I am going to be involved with the Q&A at the end of the presentations. I'd like to thank Strat Pharma for organising the symposium and also inviting me to present some of my own data, but also the data of my colleagues in the United States. What's really stimulated me in the use of StrataMGT is the patient response that I've had to very difficult, underdiagnosed, undertreated conditions that are very major in affecting the quality of life of our patients. For this slide, I have no disclosures to make for this presentation. What I'd like to be looking at is the evidence that we have already. There are completed trials and there are ongoing trials. My first trial was started in 2017 when I was presented with this small tube of gel with the question, would this help women with chronic vulval conditions? It was well known to be effective in the use of treatments for burns and wound healing, and I thought, let's give it a try. Because the patients that I was seeing were uncontrolled cases with long-standing lichen sclerosus. They either had failed treatments with other topical preparations, and with this as a novel topical gel, I think it was worth a trial. At the same time, Mark Winter on the West Coast was looking at the efficacy, safety and quality of life. And then I embarked on a much longer trial which was published in 2024. Dr. Goldstein in New York was also undertaking efficacy and safety trials. My American colleagues are having significant improvements and information coming from their ongoing trials. This slide shows the pilot study that I did with 19 women. The symptoms that are very important to women and also to us as clinicians are pruritus, itchiness, soreness, tenderness, dryness, burning, and dyspareunia, a very major problem with perimenopausal and menopausal women, affecting their quality of life, stinging with urination, irritation with clothes, and burning. So what we can see in this slide is that there is a very dramatic decrease in the first 6 weeks of treatment. And it was the patient's response that then stimulated me to suggest that we looked at ongoing treatment over a period of time. So we then changed the protocol, got ethics approval to continue the study. At the same time, Dr. Winter was looking at quality of life, and with these vulval conditions, there's a very significant drop, the biggest in that first 4 to 6 weeks, and continuing on over several months. So we've got a number of changes from various sites that show that there are significant problems. The symptoms that I was looking at on the long-term study were dyspareunia, a very major problem. dryness, pruritus, and burning. The information here shows, again, over these first weeks, dramatic reduction, but also over the 2 years, an ongoing and sustained treatment. So the two groups of women we looked at were vulvovaginal atrophy and lichen sclerosus. We also see on this left side a progressive improvement in the visual appearance of the vulval skin. This graph shows us the effectiveness of the long-term study. Again, the symptoms we mentioned before, again, are listed here. And what I was surprised with was the compliance that the patients had once their very annoying symptoms were being treated, and how they maintained the application of the gel. I think part of this comes from the acknowledgement that lichen sclerosus is a real disease. It's chronic, it's undertreated and underdiagnosed, but once it is, women are very, very appreciative of ongoing management. Similarly, the effectiveness of GSM and the acknowledgement that this is a problem will help with ongoing treatment and effectiveness and change in quality of life for women. This slide shows on the left very marked eosinophilic infiltrate and inflammation in a patient with lichen sclerosus, and then 10 weeks of treatment with StrataMGT then shows what is a much more normal appearance of skin with a marked reduction in the inflammatory infiltrates underneath that area. This correlates with the quality of life improvement in these patients that were biopsied. One of the ongoing trials now is to look at the non-inferiority of StrataMGT with a topical estrogen preparation. This is being done in the United States where there is an E2 preparation. Unfortunately, Australia only has an E3 preparation, and I couldn't be involved with adding patients into this study. However, what it does show with these interim results, there are clinical symptoms of severity that are essentially effective with both the strata and also the topical estrogen. This slide shows us the physical changes that are being assessed at the same time. And as you know, with lichen sclerosus, things like contracture of the introitus, dryness, erosions, labial fusion, labial resorption, scarring, thinning, and a generally fairly uncomfortable vulval situation. And with continued topical use of both these preparations, there is a significant improvement. This slide shows us a quality of life change from a high level here at baseline, and over 3 months a significant decrease, and this continued up to the 6 months with the interim results, so that we've got clinical signs, patient symptoms, and levels of patient symptoms that are improving. And we're particularly looking at itchiness, burning, pain, irritation and dryness. So again, we've got more information that shows StrataMGT is significant, improving quality of life for our women. This again is another chart showing symptom severity progression over time. Again, high levels here, dramatic decrease in the early months and continue on with decrease, but also continuing on with significant improvement over time with the same group of symptoms that we looked at previously. This is an ongoing study, and I really look forward to seeing the results of this with large numbers of patients. This slide again confirms that there are changes at the 6-month stage with signs of the severity of the disease, and this fits with the patient symptom profile. These interim results here are from 66 patients that have completed the study so far, and we've got a significant adherence to the treatment with a regimen of 6 to 7 applications per week, with 2 applications morning and night. My patients are encouraged to use them at other times if the symptoms are tending to have a flare, and we can see that there is ongoing improvement with time. As I mentioned earlier in the talk, it's very important to see how our patients are responding to a novel treatment. Acknowledgement of their disease process is really quite important. And once we've acknowledged that, and we've actually can agree that we are working with those patients, acknowledging their symptoms as very significant and major problems with quality of life, they will be adherent to the treatments we offer. And these are a collection of some of the comments that I made during my follow-up visits with these patients. I didn't realise how bad it was until now things are better. I used to pass out with pain, severe pain with superficial dyspareunia. Now that's gone. Other comments, this has been life-changing. I am so happy with the outcome. Now in this left slide, I'm not quite sure what I meant when I wrote no, T-E-A-R-S. I didn't know whether that was tears of pain or tears with the skin, but whatever, it's proven with the patient's feedback that both of these things do settle down. In our weather with high humidity, patients often have flares and they settle down with extra applications of the gel. Night itch has gone. Excellent response, no tears, it's amazing. So it's this involvement of patient care and their responses that's stimulated me to continue with this novel gel preparation. So I think we've shown that there are long-term symptom control. Once we've acknowledged the patient and we've got the patient's support and there is consistent follow-up, there will be significant adherence to treatment. In my study, I was quite surprised at this. We had a 90% adherence, particularly when the patients were engaged with their diagnosis and they could see symptom improvement, but also see physiological skin changes. So if we've got well-informed patients, they will be very compliant and keen to continue with the preparations. I hope this has been of interest to you. I look forward to being involved with the Q&A a little later in the day. So thank you for your attention to my talk, and I look forward to being involved in the Q&A.
Thank you. So I believe Dr. Hall is now going to join online. Hello, Dr. Hall, can you hear us? Yes? Okay, fantastic.
Yes.
So we open the room for questions. If someone would like to take the microphone, please go ahead.
You can reach the microphone, yes, please?
Yes.
Yes, hello. Thank you for your presentations. I'm Fatima from Switzerland. I have a specific question for some cases that I have. What is your experience with women having already phimosis and fusions with the StrataMGT, and what would be your treatment approach for those women on a long-term basis?
Could you hear the room, Dr. Hall?
Yes, I could.
Oh, okay. So,
the studies often talk about putting applications on twice a day. On my patients with severe disease, in the initial stages, I suggested that they use the cream each time they voided to provide a protecting gel over the skin to avoid the ongoing irritation of urine. And the gel itself gives a great deal of soothing to the very irritated skin and stops scratching and further irritation from clothes. So I think it's using more cream than the baseline twice a day.
Maybe I do a reformulation of my question to be more clear. What is your experience on the improvement of architectural changes with the StrataMGT on a long-term basis with women who already have the phimosis and the severe atrophy and fusion? And do you recommend a combined approach with, for example, a corticosteroid treatment as well to help improve these architectural changes that are already there?
Yes, I do. And I think that combination therapy can also involve a topical estrogen preparation, because there's often, these women are often older, they're showing menopausal atrophy, and I suppose I would start with some strong high potency steroid as well as some estrogen, and then as an intermittent treatment during the 24 hours, add additional strata gel. And again, that depends on the severity of the case. The last thing I do with these patients is any surgery, trying to create some sort of opening is only going to get more scarring and more inflammatory change.
Thank you.
Hello. Yes?
I've got two questions, if you don't mind. You presented the results of your treatment versus estrogen treatment. Has the study been done against the standard treatment of corticosteroids?
Maybe I can take that question, if that's okay, Dr. Hall. So we have presented data for Lichen patients. We showed the preliminary data that allowed us to then move into our randomized controlled double-blind study, which is running at the moment. So we had to use this preliminary data to show that there is efficacy in the reduction of inflammatory infiltrates, because we are competing, let's say, in the design versus the standard therapy for preventing also squamous cell carcinoma. So once we've seen there is a reduction in the inflammation, so we can ethically approach this study in a one-to-one comparison. So this study is running at the moment. We have recruited enough to finish the study in the next weeks. So hopefully in the next edition of this conference, we will be able to show you the comparison one-to-one versus steroids. So today, we've only seen the preliminary data, sorry, the pilot data. So I hope that answers the question.
So the second question is, have any of your studies shown protection against squamous cell carcinoma with this treatment?
That is not part of the design. So we've only looked at the reduction of inflammatory markers, so the infiltrates. So it is an indirect measure. So we've not looked long-term at the reduction of squamous cell carcinoma risk. At the moment, it's an indirect measure. So that's why at the moment, we still recommend the use of clobetasol as standard of care with management of symptoms with StrataMGT. Hopefully, with the time when we have more data, we could eventually say that clobetasol is no longer necessary, but that's not a claim we're doing today. So thank you very much. Yes.
And then I would like to make a question also. And in your portfolio, for how long the patient, apart the treatment, the effect 3 months, 6 months, but how long the patients have continued the treatment? Because, you know, being a chronic diseases, what we are afraid is that you can have an improvement, but then when you stop, the diseases will start again. Then what it was your experience?
Yes, I'm not sure if, did we lose a connection with Dr. Hall or? We don't have it. Okay, sorry. Yes, so we have experience now with patients over 2 years and in some cases over 4 years. And one of the key questions has always been, well, what about recession? What about treatment adherence? What about management of symptoms over such a long period of time? So obviously in this 4 years that we have been gathering data, there's been quite good control over time, no adverse events of any sort, so it's quite a safe approach to manage the symptoms of these patients. But I actually wanted to ask Dr. Hall if he's seen some recession in some of his patient cohort that joined the study. But from experience, I think it's not been the case. But because the patients have been surprisingly very adherent to the protocol. So actually, we don't recommend such a frequent application. So in the study, it was a twice per day daily application. Now we have seen that less frequency is also as efficacious. So I was hoping to ask the question to Dr. Hall, but so yes,
Thank you.
It is a case. Please, yes, thank you.
Good morning, and thank you in advance. Is it possible to use the gel with electroporation to improve the absorption with the radiofrequency or not?
It's a good question, but the nature of the gel, it's designed to stay on the surface. So you need to imagine it like a liquid wound dressing. So it is not a topical preparation designed for absorption. So even if you damage, or if you improve the absorption with other energy devices, the gel will still coat the vaginal mucosa and stay on the vaginal mucosa. So it's not related to absorption, the efficacy. Actually, the efficacy is due to this film coating the vaginal mucosa and taking over the functionality of this dysfunctional epidermis. So it's not related to absorption. So in this case, it would not be beneficial.
Okay, thank you. And is it possible to buy in Italy online? Because I saw that actually it's not possible.
So right now it's not possible in Europe, but it's about to be in the next weeks. So we're launching it officially here, but then the product is not in the warehouse yet, but it will be hopefully very soon. So that's why we are presenting you the data today. But so a little bit of patience. Thank you. And I think that's all the questions for today. So it was a pleasure to have everyone in the room. One more.
Even more.
Thank you. Tina Rosland from Norway. I was wondering about the concomitant use with steroids. As it makes a film, wouldn't it decrease the absorbance and the efficacy of the steroids? And if you use both, how should you use it to not hinder the effect of the steroids?
Yes, very important question, thank you. So yes, you're right. So the product is coating the vaginal mucosa and forming a film, so it may affect the absorption of clobetasol. So as Dr. Hall was explaining before, the treatment algorithm, probably we should move slowly from the use of the clobetasol into StrataMGT. So in the first phase of the treatment, when the symptomatology is still very high, we may then reduce the frequency of application of clobetasol, but what we would do is to space out the application between the products. So we would not recommend to use it in the same moment. So if you're applying the steroid and then StrataMGT, should not be at the same time. So one product could be in the morning, the other one could be in the evening, and that could be enough space for the film to actually dissolve over time, or well, being ejected over time, so we allow the steroid to be absorbed. So as long as we don't use them at the same time, we are okay in that treatment algorithm. And then, as we said, the plan is to slowly reduce the frequency of application of clobetasol. But it's an important question. Thank you.
And I would like to add a question. You are speaking about the steroid. When we speak about steroid, mainly about glucocorticoids, the clobetasol. But my other question is that one. In this kind of patients, we were using also a series of possible treatment we have tried. We were not successful for the lichen, but to try to give estrogen or androgen by vaginal route, in addition to eventual also a general therapy. But mostly in elderly population, local topic estrogen in the vagina can be helpful. The association of the external treatment with StratPharma and endogenous estradiol have any estradiol or androgen have any contraindication?
No, not really. So in reality, this technology is not a pharmacologically based approach. So it is it's a medical device. So we are achieving the effects by physical action. So as we said, we create a film that takes over the functionality of the epidermis that is broken or dysfunctional. So in reality, we could combine it with other pharmacological therapies. The goal is to reduce the dependency of them. So eventually, for these patients that have not seen an improvement, or maybe they are at risk of, well, there's always a bit of controversy with the estrogen, should we use it or not, with cancer survivors, and definitely the patients are a bit sometimes not happy with using estrogen. So this is a very good alternative because it combines with any pharmacological approach in that sense. So okay, there's no limitation.
Because this is very important for the chronic use, because you know, we have in our daily practice that this can happen in a younger time, but the woman, she can live over 30 or 40 years. Then the addition of possibility to have an external therapy to prevent and to ameliorate they're not only dermatologic, but mainly dermatologic aspects of this organ, and in addition to protect the vagina for all the other aspects who can improve the quality of the organ. Thank you very much. Yes. And please, there are other questions, because you know, we don't have, any of us have used it until now, and then we are all waiting, but this was a really clinical problems that inside to our society, we decided that yet we don't have the solution for the lichen, and then we need to have to present, it was our perception, it's very important to present this kind of data to you, as it will be soon available also in Europe. Thank you.
Thank you so much.
Thank you very much to all, and thank you for coming to us.